My portion of the symposium really sets the stage for the modern advances in the treatment that are under clinical development and reviewed expertly by my colleague, Andreas Reiter. Essentially, the take-home messages of this talk within the symposium is that myelofibrosis is a heterogeneous disease in presentation and clinical course, and treatment is goal-oriented and personalized to each patient. JAK inhibitor therapy really was the first major advance in MF therapy based on the understanding of hyperactivity of the JAK-STAT signaling pathway, and has led to the widespread use of Ruxolitinib since approval in 2011 in the United States, and now Fedratinib since approval in August of 2019 in the United States, and now in Europe. Ruxolitinib or Fedratinib can be used first-line therapy for patients with intermediate and high-risk disease, particularly those patients with symptomatic splenomegaly or systemic symptoms. Fedratinib is effective as a second-line JAK inhibitor therapy based on the Jakarta-2 phase 2 study. Unfortunately, JAK2 inhibitors, although they provide excellent benefit in terms of symptom and spleen relief, they do not ameliorate anemia. Therefore, anemia-directed therapy is limited and represents an unmet need. Hematopoietic stem cell transplantation remains the only curative treatment option, which is unfortunately available only for a fraction of patients. Therefore, there remains significant need for further clinical development of novel drugs, either alone or ideally in combination with JAK inhibitors, to improve the various aspects of the disease and ultimately to extend survival.